there's a whole load of technical stuff that needs to happen in terms of assessment and managing processes that need to happen for the patient to get through a brain injury admission. And that's a really, really important sort of expert bit of care. And I guess in the family therapy literature, you might sort of call that, I guess, a domain of production. So it's sort of attending to the things that need to be done in terms of sort of technical things, bureaucratic issues, and so on. I think probably the bit that we get a lot of, the bit that we find particularly valuable, and I think that families, I think in their anecdotal feedback to us about what's important, are the things that they find important are when we're kind of accompanying them and their loved one, and we're being with them in a way that kind of maintains a sense of who they are. You know, I guess you could use the word personhood, and that's a really important thing. So I mean, I think one of the things that we probably struggle the most with in terms of families having a poor experience is when they feel that the personhood of their loved one has not been respected. So in the final analysis, when you kind of go back to it, you know, issues with, you know, communication, poor care, things that impact upon the family in some way, very often related to the fact that families feel that their loved one isn't being recognised or seen, or that the pain that they're feeling for the loss of their loved one and what their personhood is not being respected in a way. So I think you know, it's a sort of key, I guess, a guiding light, if you want, to sort of guide your practice, is to always try and inquire of the family, you know, even when that person can't express themselves or is in is a very sort of low arousal state, is that you're trying to speak to them about who that person is, who that person is to them, because that's sort of created in the space between people in their family and close relationships, and I think families value that.
Actually, to have the time to look at photographs of the family, get to know the family and the patient, and yeah, be able to kind of treat them as an individual.
You might have a young person who suffered a very, very severe injury where the prognosis is really, really guarded. You know, it's very uncertain whether they'll ever wake or not. And anyone who works in this field will know that there's often a lot of sort of contention between clinicians and families about interpreting of signs and things that, you know, someone is doing. So does it mean that they're conscious? Does it mean that they're doing that with volition? And I guess we kind of, you know, we accept all of that, and, you know, but part of our role isn't to sort of extinguish hope for those families, and part of our role is to sort of, you know, if a mother is seeing her son grimace in a certain way, and it reminds her of a way that he used to grimace when he was a child, and then she puts together a sort of an explanation as to what that means, and that gets her through that day or that hour, then to us that's an acceptable thing to do. And it's not denying the seriousness of the injury or telling them lies, but it's something about meeting them where they are. That's something that's can be really, really, really difficult. I guess people often, practitioners will often say, you know, we don't want to give the family false hope, because, you know, there's an uncertain or very guarded prognosis for someone's recovery back to a life that they and their family would wish. And in a sense, you know, you sometimes get there's a sort of an anxiety in teams that what you need to do is, you know, manage expectations and damp down unrealistic hope. And I guess there's an element of truth to that. You have to be honest and transparent about the things that you're seeing, but it's not our role to extinguish people's hope. And I guess, you know, part of my thinking about this is, I guess, based a little bit on someone like Kathy Weingarten, who's a family therapist, who talks about the idea of reasonable hope. So that hope is something that I guess does spring out of despair, and you have to be honest about that. Families are in despair, and you can be quite despairing as a practitioner. But what you're sort of aiming to do on a sort of a daily basis or in your practice with the families and the patient is to look for signs of hope and to create that with them. So it might be the smallest possible thing that, anyone who's nursed these very complex patients, that you can get an immense amount of joy from a positioning or a managing of someone's continence, or, a sore healing, or, a period of time off of a ventilator, or whatever it is. And that small amount of hope can get someone through a day. And it allows you to get into a space relating to a family in a way where you're not pushing them into a space of despair, and you're not sort of just recounting sort of rather grim medical prognoses, which may or may not be that useful for that family at that point in time. Everything has a time, and sometimes families will have to face up to some difficult diagnoses and decisions, and sure, there's a time for that, but equally there's also a time when you have to sort of work on fostering hope with people, and that's a reasonable hope.
There's something quite special about spending or being with a patient through that whole pathway and seeing them at different stages, and being able to adapt our practice to the patient and what they need, but also adapt or change the conversations that we're having with families. So, we might meet a family and their loved one is sedated on intensive care and they're unsure about what the outcome is going to be. And then we might see them on a ward where they're presenting with challenging behaviour and they're swearing or, assaulting staff, and that's not in nature of their character, and that can bring a lot of distress. And I think to be able to kind of say, no, we know your relative, we were there at the beginning, we've had those conversations with you, and we know that that's the brain injury, I think adds something to it. I guess there's also, just in terms of, best interest decisions and some of those conversations that we lead on, and it's what the patient's values and kind of knowing about that, because what someone will see as a poor outcome and would not be acceptable for them is something that another patient might, that might be something that they wish for. So if they trust us, and if we say we don't know, or we give an opinion that's different or give them options, I think that helps them to know that we're not kind of making something up or fobbing them off.
You might get asked to go and see a family who are framed in some way as being difficult, for example, the difficult family, and very often they're distressed because of what's happening to their family and to their loved one. And I think part of the thing about relationships is that we are also part of that system with the family and the care system around them. So the way that people relate to, speak with, foster hope with families will have effects upon the family.
I would say my advice would be to be open to give families time and to provide some consistency. So I think to be available, and to be open to kind of hearing their views and spending the time to kind of get to know the patient and their families is all really important.
So I would say something that was probably complementary to that, which would be to in your interactions with families, particularly when you're being, you notice you're feeling something in your interaction with them, because it can be difficult, is that you stop for a minute and you try and reflect upon yourself. What's my position in this? What's my beliefs and values about what should happen here? What's different from me in relationship to this family? Who am I? What do I look like? Where do I come from? How do I speak? And think about those sorts of things, and try and reflect a little bit on your own position. So I think broadly that would be called self-reflexivity. So trying to think about that, and build upon that when you're interacting with families.